our midterm. This is our Prelingual Sensorineural Hearing Loss Basics. It was rude of me last time to go through a ton of material, not really thinking through the order of events. Typically, by the time I would get to this lecture, we've already covered a lot of the basics around sensorineural hearing loss. And I've been switching things up a little bit this semester in terms of the timeline, the order of presenting the materials. So I apologize. Some things make sense, and then when you do it, it's like, not so much. So backing up just a little bit, and we're going to cover this stuff. By the way, coming to you from South by Southwest in Austin, Texas, hoping that we can spend just a little bit of time here this morning covering some of these pieces, because I've got a full day of scanning, and I got to talk with a couple of tech reporter folks. So this is going to be an interesting day. So we covered some of this stuff in our pediatric lecture, talking about the Joint Committee on Infant Hearing, JCIH, and their 2007 position statement. Just a couple of things to focus on with this. Talking about surveillance specifically, again, something that I really focused on, was just talking about how just because a child passes newborn hearing screening doesn't mean that they can't get a hearing loss in the future. And unfortunately, I saw it a number of times where a pediatrician would say, well, their speech delay has to be from something other than hearing because they passed newborn hearing screening. And this might be like an 18-month-old, 19-month-old child who's not talking yet. So this is something that I pulled directly from the JCIH piece. I'm going to read it off to you, but just noting that there's some of this that I've highlighted in yellow. Comprehensive audiologic evaluation of newborn and young infants who fail newborn hearing screening should be performed by audiologists experienced in pediatric hearing assessment. We are going to talk a little bit about what does pediatric hearing assessment specifically mean. The initial audiologic test battery to confirm a hearing loss in an infant must include physiologic measures, ABR, OAE, tympanometry, and when developmentally appropriate behavioral methods. So the concept of a cross-check principle that says just because your ABR tells you something doesn't mean that you don't have to do some kind of behavioral hearing testing when a child is capable of doing so. Confirmation of an infant's hearing status requires a test battery of audiologic procedures to assess the integrity of the auditory system of each ear, not just an ear that doesn't pass. A child passes left ear, doesn't pass the right ear. The ABR needs to be done on both ears, not just on the ear that the child, that did not pass. To estimate hearing sensitivity across the speech frequency range, that means not just doing an ABR using a click evoked ABR. You need to do frequency-specific ABR. To determine the type of hearing loss, because of course it's very important to know, is it a sensorineural loss or a conductive hearing loss? To establish a baseline for further monitoring, knowing that hearing loss can be progressive, and to provide information needed to initiate amplification device fitting. You need to have a good enough ABR, good enough frequency specificity to be able to fit hearing aids. Comprehensive assessment should be performed on both ears, even if only one ear failed the screening test. The reason for that is because, specifically with CMV, you can have progressive hearing loss in both ears, but it can be asymmetric. So one ear might not pass the screening, the other ear does pass the screening, and within 3 weeks, hearing in both ears might be down. And it's also, for instance, things like enlarged vestibular aqueduct. There are multiple other things that would cause a progressive hearing loss in both ears, but specifically looking at enlarged vestibular aqueduct or other temporal bone malformation and cytomegalovirus are two really common reasons why a child might have progressive sensorineural hearing loss. So audiologic evaluation, birth to 6 months, 6 pieces to this. First, getting a good case history. This is for both the child as well as the family, specifically looking for risk factors, family history of childhood hearing loss. If there was anything wrong during the pregnancy, such as mom got CMV while she was pregnant with the child. Parental report based on their observations. Parental report is really, really important. Parents are very, very good historians when you focus in on what is it that you see the child is doing. Even in a newborn, they're able to demonstrate a lot of things. Not good enough consistent enough for behavioral hearing testing, but they're able to show a lot of what their auditory system is doing for them. We do a frequency-specific air conduction and bone conduction ABR. Click-evoked ABR if there's concern for auditory neuropathy spectrum disorder, ANSD. So that's something that we're going to talk about here a little bit, at least today, is auditory neuropathy spectrum disorder. And noting that the ABR has to be performed using rarefaction and condensation, that rare and con. Rarefaction and condensation clicks so that we can look for some of the hallmarks of auditory neuropathy spectrum disorder. If in number 2, doing frequency-specific ABR, there's no response, that's when we would do a click-evoked ABR just to see is there any hearing sensitivity that we can measure, at least with clicks. Distortion product or transient evoked otoacoustic emissions, 1 kilohertz probe tone tympanograms. And the reason why we do 1 kilohertz probe tone rather than 226 hertz probe tone is because of ear canal compliance. Using a low frequency, you actually are measuring the compliance of the ear canal if you've got fluid behind the eardrum. We'll talk about that just a little bit later when we talk about tympanometry. And then even in children under the age of 6 months, you might do some behavioral observation audiometry just to see is the child demonstrating any awareness of sound. This is particularly important if a child has auditory neuropathy spectrum disorder. Just because they have some abnormal findings on an ABR does not mean that their hearing system is basically just off. They may actually have some really fairly good hearing. So that's where we do cross-check with behavioral audiometry. So in children between the ages of 6 months and 3 years, again, you're figuring out, taking important family history and child history on the child as far as whether or not they're establishing their communication milestones. Children should be talking sometime between, saying their first words between the ages of 12 months and 18 months. Making many more attempts to communicate, receptive language outpacing receptive language, typically. Receptive language outpacing expressive language, typically. What a child's doing if they have hearing loss, that's important to understand as far as them hitting their communication milestones. Doing behavioral audiometry using pediatric appropriate techniques, doing otoacoustic emissions when appropriate, doing acoustic emittance, temps, and middle ear muscle reflex. And if you get unreliable results on behavioral audiometry, doing an ABR, or if this is a child that previously has not had an ABR and behavioral audiometry is suggesting a hearing loss, ABR would be necessary prior to fitting with hearing aids, unless you're absolutely convinced that the child is very, very good and very clearly demonstrating where their hearing sensitivity is. That said, if an ABR hasn't previously been performed, an auditory neuropathy spectrum disorder type of hearing loss can masquerade as your typical sensory neural loss. And so in children up to age 36 months, pretty much across the board at Boston Children's, we would always do an ABR. Even when we had really good, clear behavioral thresholds, we would just want to rule out possibility of a child having auditory neuropathy spectrum disorder prior to us fitting hearing aids. It just helps in anticipating what the benefit from hearing aids might be. So currently at this time, auditory steady state response, ASSR, is considered insufficient to use as a sole measure for physiologic assessment of hearing in newborns. Using middle ear muscle reflexes, you can do it, and I've got some slides in here showing what happens when you are doing it, when you're doing when you do middle ear muscle reflexes. But it's something that you need to make sure that you understand for your own clinic how successful you can be at doing reflexes. across the board, just JCIH doesn't recommend use of middle ear muscle reflexes as something that's more than just vaguely informative. So in children who would pass newborn hearing screening, or they would be at high risk, and this would be something for children less than age 6 months, or if they referred on the universal newborn hearing screening, children would be given an appointment for an unsedated ABR, so in natural sleep, within 3 weeks of discharge, telling the parents to bring the baby hungry and tired but not yet asleep. That's easier said than done if you've got someone, a baby coming in the car in a car seat. And we would book a 2-hour appointment. We would do 1 kilohertz tympanograms, and these are referenced to normative data published by Margolis et al., publication date 2003. We'll look at those. And we would do tone burst ABR, maybe or maybe not doing clicks with it. And we would do tone burst ABR in this order. We'd do 2 kilohertz first, then 4 kilohertz, then 1 kilohertz. What's considered as dB NHL, dB relative to normal hearing level, would be established from behavioral responses to the tone burst, to 2 kilohertz tone burst, to 4 kilohertz tone burst, 1 kilohertz tone burst, right across, in a jury of 20 normal hearing ears. So 10 people, each, 10 left ears, 10 right ears. And the correction from dB NHL to dB HL, meaning whatever you get on the ABR response, how you might interpret that dB NHL over to the actual audiogram measured in dB HL would be informed by Stapel's paper published in 2000 and by a paper by Vanderwerf et al. Published 2009. So that they did some fantastic work. I'm not going to make you read it. It's a super long paper, the Vanderwerf et al. Paper, where they would have children with very good, clear behavioral audiometry, and they would do ABR and then match up what are their responses in NHL to HL. So here's an example of a child with normal hearing sensitivity, left ear on this left side, right ear on the right side. What you see, and again, I hope that my cursor, my arrow is showing up. Left ear, 1,000 hertz at 30 dB NHL. You've got multiple runs, and you get a dip here right around 10 milliseconds latency. 1,000 hertz, you get, again, that dip. 4,000 hertz, you get multiple repeatable waves, and at 8,000 hertz, very clear, good wave morphology. And this last wave here, this would be wave 5 of the auditory brainstem response. Pretty good clear waves on the right ear at 8,000 hertz at 20, 4,000 hertz at 20, 2,000 hertz at 30. 2,000 hertz at 20, it looks like there is a wave there. And then at 1,000 hertz at 40 dB NHL, very obvious response. And at 1 kilohertz 30, not as clear a response. So one of our mantras would be, if you don't know if it's an ABR response, go up in level. Is it bigger? Is that wave 5, Roman numeral 5, is it bigger and is it earlier? So let's look at 2 kilohertz at 30, 2 kilohertz at 20. Is the wave bigger and a little bit earlier, and earlier being left along the x-axis? And from 2 kilohertz at 20 to 2 kilohertz at 30, yes, the wave is bigger and it's earlier, and that would suggest that this little blip at 2 kilohertz at 20 is a true ABR response. Same thing here, 1,000 hertz at 40. There's a nice, clean, clear wave 5. It's repeatable. Here at 30, it is there. It's subtle, but it is there, as proven by going up by 10 decibels. The wave gets bigger, it gets earlier, therefore there is a response down at the lower level. So here's the norms for 1 kilohertz tympanometry in neonates. The median acoustic admittance as a function of ear canal air pressure, the 5th percentile and the 95th percentile. So this would be in the normal range. If the tympanogram falls, the 1 kilohertz tympanogram falls in this gray region, that means it's a normal tympanogram, consistent with there being normal middle ear function. In absolute numbers, here's the norms So the reason why we're using 1 kilohertz tympanogram is because at the higher frequency probe tone, that signal is transmitted more easily through the middle ear system than it is through the walls of the ear canal. In neonates, the soft tissue is very floppy, and as you increase air pressure and decrease air pressure, you can actually expand and drop the sides of the ear canal. And if you're testing with 226 hertz probe tone, even if you have tons of fluid behind the baby's middle ear, behind the eardrum, and that eardrum is not moving at all, using 226 hertz probe tone, the ear canal wall can actually flex back and forth and transmit low frequency sound through it, mimicking a normal looking 226 hertz tympanogram. Then doing 1 kilohertz tympanogram, you'll see flat because the 1 kilohertz doesn't transmit through the walls of the ear canal. And if the eardrum is not mobile because there's fluid behind it, then it actually is showing you a flat 1K tympanogram. So you have to use 1 kilohertz right up until a child is about 6 months old. Typically, by the time they're 3 months old, their ear canal wall is firm enough that 226 hertz probe tone should be successful. But if you get a normal tympanogram, 226 hertz probe tone, that may or may not be indicative of there being no fluid behind the middle ear. Do 1 kilohertz probe tone, and if you do get good eardrum mobility at 1 kilohertz, then you're confident that yes, looks good, that there's no fluid there. Middle ear muscle reflexes. Middle ear muscle reflex, just as a quick background, the input to it is cranial nerve 8, our auditory nerve. The output is cranial nerve 7, our facial nerve. You can do, it stimulates both the ipsa and the contra-cochlear nucleus. It also stimulates the contralateral superior olivary complex. Okay, it is a very clean, very pretty, very obvious response. And this is actually something that is measuring the lower end of the ascending auditory pathway. Can you do it? As early as 1978, shown that only 4% of infants under the age of 48 hours actually had an acoustic reflex with low frequency probe tone. Then right after that, it was demonstrated that the optimal probe tone for a listening reflex was between 800 and 1800 hertz. In neonates, only half of them showed an acoustic reflex at 220 hertz probe tone, but bumping up to 660 hertz probe tone, it was observable 80% of the time. So what's that mean? You have to use a higher frequency probe tone. Let's take a look at this. So the Weatherby and Bennett, in neonates, how often was an acoustic reflex detected with a probe frequency of 220 hertz, 400, 500, 600, on and up? Look at this. Between 800 hertz and 1800 hertz, an acoustic reflex was detected 100% of the time. So, as an example, so here's 91 dB in adults using 1000 hertz probe tone in an adult. Beep. See where this notch is? That's where the beep went in, and it causes a reflex. It comes back, beep, comes back. Here's at 87 decibels, 83 decibels, 79 decibels. So normal acoustic reflex growth in an adult. Now here's using 800 hertz probe tone with the stimulus beep, the beep, that would cause the acoustic reflex. That's using 2000 hertz ipsilateral stim. All right, so playing it at 60 decibels, at 65, at 70, at 75, what you see is that as you go along the right side, you don't get any signal, no reflex. Here they're getting a reflex. This is at 68 decibels, getting a reflex. At 73 decibels, getting a reflex. At 78 decibels, getting a good reflex. So it is possible to measure middle ear muscle reflexes in neonates. Not something that's well studied, not well reported yet, so JCIH doesn't really focus on it. But just wanted to give you all just the full perspective of the full complement of the physiologic measures that you can use for assessing hearing in newborns. So now switching gears, thinking about that medical evaluation aspect of this, recommended access for medical evaluation from the JCIH indicates that medical workup for infants with confirmed sensorineural hearing loss is necessary. And in clarification of that, that needs to focus on genetic testing and genetic counseling. Every infant with confirmed sensorineural hearing loss has to be evaluated by an ENT, quote, with knowledge in pediatric hearing loss, whatever that might mean. Every child with confirmed sensorineural hearing loss should have at least one evaluation by a pediatric ophthalmologist, eye surgeon, and risk factors. There's a risk factor table, delayed onset and congenital. We need to take a look at all of those and consider what aspects of this are necessary. Looks like I repeated myself here. Sorry. So the medical workup, historically, etiology was found in only half of cases. The high-risk register, if you recall from the JCIH 2007 position statement, there were 11 risk indicators that put a child at quote-unquote high risk. It's understood that half of all children with congenital or prelingual sensorineural hearing loss, half of them are on that high-risk register. The other half would not have any of those high-risk indicators. There's historically been some resistance by physicians to pursue etiology workup for the sensorineural hearing loss, given that it can be expensive. Only half the time you find out why, and there's been kind of a concept of, well, you can't do anything about it anyway. Well, you can't do give medication or surgery, except sometimes actually you can give some medications to help stabilize hearing. And benefits to it for why to do a workup to understand what are the underlying causes of the sensorineural hearing loss. Parental peace of mind. If it is a genetic underpinning, then it can greatly assist in a family in family planning. What are the chances that they're going to have a second child with hearing loss as well? If you do know why they have a sensorineural hearing loss, you can anticipate whether or not the hearing loss is stable. Is it a stable sensorineural hearing loss, or might it progress? You can anticipate if there's comorbid conditions, if it's a syndrome associated with sensorineural hearing loss and, say, vision loss, like Usher syndrome. That's a really big deal. Is it comorbid with something else, like Jervell and Lang-Nielsen syndrome, where you have a congenital heart problem that can be managed with medication? Those are those are very important. Is it congenital cytomegalovirus? That's an exogenous cause to the hearing loss. It's something that came from the outside, an infection. Bacterial meningitis that can cause scarring in the cochlea, is basically a bony overgrowth, and might cause you not to even be able to get a cochlear implant in that child's cochlea, versus endogenous cause like connexin 26 gene mutation or a syndrome associated with sensorineural loss. So as of 1999, 68% of the time sensorineural hearing loss etiology was found. Now 70 to 80%, depends on which tests are performed and to what extent those tests are done. So much more often than half the time, sensorineural hearing loss etiology is found. We saw this last time, but just to take a look at it again, this is 1 through 5 of the high-risk register for JCIH 2007 position statement. 6, 7, 8, 9, and 10. I just want you to familiarize yourselves a little bit with this. What are the syndromes? What are some of the physical findings? For instance, this white forelock, like literally like right here on the hair, it's white. That's associated with Waardenburg syndrome. It's an integumentary condition. Neurodegenerative disorders, this thing called Charcot-Marie-Tooth syndrome. It's associated with auditory neuropathy spectrum disorder. culture positive findings such as cytomegalovirus, meningitis, head trauma, and even chemotherapy. We saw this last time. Tests to consider. Boy, that's a pretty good group. The connexin 26 gene mutation for recessive sensorineural hearing loss, high yield, has educational value. I would say there's definitely some negative consequences if you don't do it. Okay. We discussed cytomegalovirus in detail last time, but looking at genetic studies specifically, the gap junction beta 2 protein, GJB2, it is a connexin 26 protein. There's also a connexin 30 protein. This is something that's an autosomal recessive condition. As noted, both parents have to be carriers for the connexin 26 or connexin 30 gene mutation. There are mitochondrial mutations. This particular mutation, A1555G, that is a mitochondrial mutation where if you get aminoglycoside, antibiotics greatly increases the risk for ototoxicity. There's this other gene, the PDS gene, that if you have a mutation of this particular gene, then you will have Pendred syndrome. It's a metabolic disorder. It's associated with enlarged thyroid. It's also associated with enlarged vestibular aqueduct, which you would find on high-res CT scan, that the temporal bone has a malformation and is associated with delayed onset and progressive sensorineural loss. There's a lot of known syndromes, many more types and genes that can be identified depending on how far down the path of genetics you want to go. Turns out that under CMV, there is a blood test for CMV in newborns, and you can take antiviral medications that can help treat the sensorineural hearing loss and some of the calcifications that can occur in the brain. So some of the brain damage might be reduced if a child is on some of these medications. The medication is called ganciclovir. That's an IV medication. Or it's possible to take an oral, which is called valganciclovir. It is not a terribly nice medication. It causes low white blood cell count, and so can cause a child to have immune compromise, meaning they're at risk for developing an infection that you might have to treat with aminoglycoside antibiotics. That said, it can cause the hearing loss to, instead of continue to progress, it can stabilize it. And I have seen it in a couple of very young children where they had a moderate sensorineural hearing loss, and after their treatment with IV ganciclovir, their hearing went up to normal. There have been other kids where their hearing is better while they're on the ganciclovir, and as soon as they come off the ganciclovir, the hearing comes back down again. But that said, it's known. It can happen. All right. Genetic studies. Let's hit this a little bit. This is good stuff, and I apologize that we didn't spend more time on it when we met in class. Syndromic versus non-syndromic deafness. Non-syndromic, as in there's only hearing loss and there's no other physical finding associated with the deafness. Non-syndromic is 2/3 of all genetic sensorineural losses, so whereas syndromic is responsible for 1/3 of deafness. Syndromic sensorineural hearing loss we'll talk about in just a minute. So non-syndromic, it's known that the connexin 26 gene mutation is 1/2 of all non-syndromic sensorineural hearing losses. So taking that non-syndromic sensorineural hearing loss is 2/3 of all genetic losses, and connexin 26 is 1/2 of all of those. 1/3 of all genetic hearing losses, meaning the genes are the cause of the hearing loss, 1/3 of them alone are from a connexin 26 gene mutation. That means the connexin 26 gene mutation is very common and is a very, it's worth doing the test for to see, is this why the child has a hearing loss? Under the syndromic sensorineural hearing losses, there's seminal work by Koningsmark and Gorlin from 1976, like a really long time ago. They indicated 8 different categories where there's a sensorineural hearing loss associated with the renal system. Syndromic sensorineural hearing loss associated with vision, associated with metabolism, associated with the integumentary system. You recall that's our skin, that's our fingernails, that's our hair. I'm going to send some lecture notes to you guys, but specifically looking at the Koenigsmark and Gorlin, this is from 1978, that there's Waardenburg syndrome, which is an integumentary-associated sensorineural loss. It's autosomal dominant. Alport syndrome, which is associated with renal dysfunction. Usher, Klippel-Feil, Hurler, and Hunter. Pendred syndrome, Friedreich's ataxia, the list goes on and on and on. But these are just some of those highlights. I want you to be familiar with these particular syndromes. Just to note, this is actually still fairly recent. The concept of the gap junction beta 2 mutations. This was only discovered in 1997. These gap junction beta 2 proteins encode for the connexin 26 protein, which, as we noted in the lecture last time, this is responsible for the ionic potassium exchange between cells of the cochlea. This is how the endocochlear potential is maintained. This is the battery that powers the outer hair cell transduction process. It was typically thought, at least way back when, that like 1997, oh my goodness, so long ago, that if you had connexin 26 gene mutation, that would result in bilateral severe to profound sensorineural hearing loss, the degree of hearing loss that would typically be considered quote-unquote deaf. Turns out that's not the case. Kanay et al. 2010, this is from Boston Children's Hospital. The range of hearing loss was from mild to profound, and it could be progressive, which was a new finding. It is population specific. It's more because it's genes. So certain populations, certain ethnicities, you're going to have more connexin 26 gene mutation than in others. For instance, African American, you're not going to find a lot of connexin 26 gene mutation. It's common in Caucasians, Eastern European Jews, the Ashkenazi Jews, as well as in Asian culture, Asian populations, you're going to find connexin 26 gene mutation. Mild to moderate sensorineural hearing loss is found in 38% of the few hundred kids that were part of the Kanay et al. Cohort, whereas the severe to profound, it was 62%. So just because the hearing loss isn't severe to profound doesn't mean that you don't need to do connexin testing. So medical workup, do you do all tests together, or do you do one test at a time, doing them in sequence? So this particular paper, Preciado et al. 2005, they had 150 children with idiopathic sensorineural hearing loss. This is serially over the course of 2 years. Kid number 1 through kid number 150 who had hearing loss that there wasn't a known cause. All of them got connexin 26 gene testing. All of them had a high-resolution CT scan of the temporal bones, and all of them had lab studies done, such as complete blood count, the BUN creatinine tests, which BUN and creatinine are testing your kidneys for certain proteins, which indicate whether function is good or bad. Connexin 26 gene mutation was identified in 12% of their 150. Temporal bone malformation was identified in 30%. So literally the high-res CT scan showed something significant, 30% of these 150 kids. And the typical, like just regular blood work showed nothing. It wasn't significant. Recommendations, if you're going to do, instead of this shotgun approach of doing all the tests, which that's expensive, they recommended that a more cost-effective workup would be, in a child with a mild to moderate sensorineural hearing loss, do a CT scan first. If that doesn't show anything, then do connexin 26 gene studies. If the child has severe to profound sensorineural hearing loss, do the connexin 26 first, then do CT scan if the connexin 26 does not come back positive. So genetic and imaging studies. So this is where that Pendred syndrome, PDS gene mutation, this is where this comes in. It's very important. Temporal bone malformations. Turns out that a lot of kids with sensorineural hearing loss have a temporal bone malformation. These malformations are enlarged vestibular aqueduct, which is one of the channels, and we'll take a look at it. It's one of the channels that communicates between cerebral spinal fluid and the cochlea. And then these other two cochlear dysplasias called a Mondini dysplasia or a Meckel aplasia. Mondini is less severe, Meckel is more severe. So a fairly common syndrome is called Pendred syndrome. This is an autosomal recessive metabolic syndrome. Okay, it messes with your metabolism. Results in hypothyroid. Their thyroid gland will be huge. If it goes untreated, they get this big enlarged thyroid called a goiter when people get up into their 20s. So it takes a couple of decades for this to form, but it kind of looks bad. It also indicates that their thyroid is not working and they may have to have their thyroid removed. Supposedly, it accounts for 7.5% of all congenital deafness. It's a pretty big number. And in people with Pendred syndrome, 80% of them have this temporal bone malformation of enlarged vestibular aqueduct. What is this? Enlarged vestibular aqueduct, it can occur in the presence of a Mondini deformity, as in it's both the vestibular aqueduct as well as a malformation of the cochlea. They sometimes have what would be referred to as a deficient medialis. That's the center of the cochlea, what the cochlea wraps around. You may not have good nerve connection. So in enlarged vestibular aqueduct, you will often see fluctuating sensorineural hearing loss. With this, it's been historically thought to be associated with head trauma. So something as like mild trauma as heading a soccer ball, that can cause sensorineural hearing loss to fluctuate, to drop. You can have sudden pressure changes, like flying in a small plane that's not well pressurized, going up too high, or scuba diving. This would be contraindicated in someone who has known enlarged vestibular aqueduct. So let's talk a little bit about this. So Valvassori and Clemis were the first people to describe enlarged vestibular aqueduct syndrome. The way it's defined, whether you have enlarged or not enlarged, is if the vestibular aqueduct is 1.5 millimeters or wider midway across this particular section called the operculum and the common crus. I don't know where those are. Just know that a radiologist knows exactly where that is and can see, aha, that channel is wider than it's supposed to be. It can be seen on a high-resolution MRI. MRI, the soft tissue lights up and the dense tissue like bone is darker, whereas CT scan is the opposite of that. The dense material is lighter and the soft tissue is darker. Air comes out black and fluid comes out gray. The brain comes out gray as well. Bone comes out really white. So turns out some people have said, well, we should just close the enlarged vestibular aqueduct, and just like surgery to try to close it. That caused hearing to just crash. And so it turns out, nope, don't touch it. Don't try to do any kind of surgical intervention for enlarged vestibular aqueduct. Don't have them play contact sports, and watch their hearing because their hearing loss fluctuates. Sensorineural hearing fluctuates. So here's enlarged vestibular aqueduct with a Mondini malformation. So here on the right side, this is on our left panel, but that's the individual's right ear. You see on the far left all these little squiggles. That's the pinna. You've got some mastoid air cells. You've got the ice cream cone looking thing right smack in the middle of the black. That's the malleus in the middle ear space. And then in this bony structure here, you see these two smaller black dots. That's one of the semicircular canals. You've got your utricle part of your labyrinth, and then you've got this thing that looks a little bit like someone hitchhiking, this little thumb thing sticking out. That is a malformed cochlea, that yellow arrow. The white arrow indicates where there's an enlargement of the entrance of the vestibular aqueduct. On the other side, we've got mastoid air cells, really obvious. We've got middle ear, this black area through here, and these two dots, that's part of ossicles. Where this white arrow is, there's this tiny little dip That's a vestibular aqueduct that is normal in size. Over here we've got utricle, and we've got semicircular canal. This cloverleaf looking thing, that's a normal cochlea. That's 2.5 turns of a normal cochlea. That's what it should look like. And then this gray thing that's like the base of it, that is the auditory nerve. Going to this next one. So this is another view, slightly a different slice of the CT scan, where there's an enlarged vestibular aqueduct. Here's your malleus, and your cochlea does look malformed in this. Switching to a different view, so now we actually see semicircular canals more obviously, and we don't see the cochlea so obviously, but you can really see the enlargement of this vestibular aqueduct. Here on this individual's right side, which is on the left side of our screen, going into the labyrinth, you can see this brief little area where the vestibular aqueduct is actually its normal appropriate width, and then going further out where it communicates with cerebral spinal fluid, then it's bigger here on that side. This other side, it looks fairly enlarged through the whole thing. So here's on an MRI. So remember with the MRI, the darker area is dense bone, the lighter areas is softer tissue, and then really light area, this is liquid. So you actually can see, like it's the cerebral spinal fluid and endolymph and perilymph, you can see the enlarged vestibular aqueduct. Down here, this is the bottom left panel. This is a normal looking cochlea, normal auditory nerve, normal vestibular aqueduct. So EVA, this particular paper is really one of the best papers that I've seen about enlarged vestibular aqueduct. Madden et al., 2003, at Cincinnati Children's Medical Center. They reviewed 77 cases of children with EVA out of 1,200 children in their database. 6.4% of their sensorineural hearing loss, 6.4% of the cases. All of them, of course, had sensorineural hearing loss. They were part of a sensorineural hearing loss database. 87% were bilateral, 13% unilateral. Half of them had stable hearing loss. The other half had fluctuating or progressive. Whether it fluctuated down and back up again versus it just progressed down depends. You can't anticipate it. But that was what they saw over the course of close to 3 years on average. But they followed some of these kids out for a pretty long time. Compared to a control group of 33 children, 66 ears, normal hearing. They did have what looked like a child with normal hearing but had enlarged vestibular aqueduct, one child. So it's oh, hey, look at that. We found something incidentally that this child we're going to follow because the child had normal hearing but did have enlarged vestibular aqueduct. That is someone that you anticipate perhaps having delayed onset sensorineural loss. So kudos, they found one kid in their quote-unquote normal group. So how often does this happen? Literature says it's from 1 to 7%. Hard to say, but it's not. It's enough that it suggests that it's worth doing CT scan because it's not a very, very small yield. It's actually a fairly good sized yield. I think we mentioned this young woman. Little girl who's, I guess she's probably now about 7 years old, but met her when she was 2 years old. We mentioned this severe to profound sensorineural hearing loss. She had a low frequency, what looked like conductive. This happens when you have temporal bone malformation. You have this pseudo-conductive loss. It is, in fact, sensorineural, but it's the way that bone conduction signals are transmitted through an ear that has a temporal bone malformation. It actually causes this increased flux of fluid because you have instead of only the oval window and a Rowden window where you only have 2 windows, having an enlarged vestibular aqueduct or other temporal bone malformation can result in a third window. It's called a third window phenomenon. When that happens, your low frequency bone conduction is basically amplified in the cochlea. And so you hear signal through the bone, through bone conduction, at levels much higher than you should, for instance, in an otherwise normally calibrated audiometer. If you see this with normal tympanogram, highly suspicious for temporal bone malformation. We found low frequency conductive hearing loss in a number of children with a number of children with sensorineural loss. We would see this low frequency conductive component and send them right over for CT scan, highlight to the otolaryngologist, and lo and behold, would find temporal bone malformation. So this particular child, she had, this is the one where mom said, does this mean she'll never get married? Which of course was an expression of mom's grief. She wanted to know, will my child be happy? Turns out kid's doing great. She's doing really good. She ended up with cochlear implant very quickly and really took to it. She had a good 18 months or so of good hearing. She passed newborn hearing screening, and for all we know, her hearing was normal until it dropped at about age 18 months. So some examples. See this low frequency kind of air-bone gap right across? Interesting stuff. Not atypical. Here's some high-res CT scans where it's just a different temporal bone malformation, something called a superior semicircular canal dehiscence, typically SSCD, but it doesn't have to be the superior semicircular canal. It can be the posterior. So this is normal. Here's middle ear space. Here's the labyrinth, including the superior semicircular canal. Top of the head is up here, bottom of the head is down here. This is all brain right across here. So in this particular view, called a postural view, which is specific to looking for this, at this very thin layer of skull between one of the semicircular canals and the brain. Here, that bone lining is dehiscent. You have brain literally pressing down on the membranous labyrinth, so the membrane with your perilymph in it. So these people tend to have incredibly sensitive low-frequency bone conduction, which means that their voice is super loud in their head. They can sometimes hear a hairbrush is like ridiculously loud. They can hear their own footsteps, like really loud. A bone-conducted signal is super loud. They have normal tympanograms. They have normal acoustic reflexes. Really important. Normal acoustic reflexes. If you had this much of a bone, actual true air bone gap, that even though your hearing isn't that bad, you will have no reflexes. You have some kind of fixation of either the stapes or fixation of the ossicles, which you won't have a reflex. But if you have a normal reflex, in fact, you might have a reflex at a much lower level that is consistent with a temporal bone malformation, and particularly in this case where hearing sensitivity is so good, a superior semicircular canal dehiscence. And it turns out they can use bone graft to, like bone paste, you can literally like close over that dehiscence, and it actually causes hearing to be better and gets rid of those the loud voice in your head, that autophony. It closes that off. And makes things better. Your hearing doesn't fluctuate. Okay, other etiologies. Do want to touch on this. Auditory neuropathy spectrum disorder. This is where your cochlea, at least up through your outer hair cells, is working fine, and the hearing loss is not in your endocochlear potential. It's not in your outer hair cells. It's in either the inner hair cell, the synapse between the inner hair cell and the auditory nerve fiber, or part of the auditory nerve fiber. It's marked by a dyssynchrony. Instead of the auditory nerve firing synchronously in response to signal in certain pitch ranges, it's not firing synchronously. It's out of order. It's asynchronous. Do Google search for auditory neuropathy spectrum disorder, or auditory neuropathy for short, simulations. It sounds like static. So instead of something just being softer, or you not having access to soft sound, oftentimes they do have access to the full range of sound, but they have terrible timing cues. So you can't hear certain things like differences in voice onset time. The word fat and vat. So a vat of fat. You wouldn't, if you have any amount of auditory neuropathy spectrum disorder, you wouldn't hear the difference between those two. It's a spectrum disorder because some people have pretty good hearing and can hear fairly well in quiet, whereas other people can't hear so well anytime. Pretty much across the board, though, in background noise, they don't do terribly well. Turns out that if you do have ANSD, you got to check to see, do you even have auditory nerves? It's possible that you could have compression of the 8th cranial nerve, and it can be associated with other syndromes that are associated with neurologic problems. This girl, Jenna, was a former patient of mine. She passed an otoacoustic emission newborn hearing screening. They didn't do ABR on her, which is too bad. She had very poor health, general hypotonia. She had to have a G-tube. She had a tracheostomy. She had no swallow coordination. She had severe gross motor delays. She was in a wheelchair. She used orthoses to hold her feet stable. However, normal cognition, very poor receptive language. The child... very poor receptive verbal language. Mom introduced ASL, and Jenna took to it in a heartbeat. Here's her audiogram. She gave a lot of good information. It's this kind of sloping, what ended up being a sensory neural loss. She accepted earphone testing for left ear, right ear. She crapped out. In sound field, somewhere ballpark to the same. And here's her ABR. 60 decibels, rarefaction condensation, no response. At 70, you get this little squiggle. Up at 90, you get the squiggle that just rings out for a while. How do we know that this is not artifact from the earphone? So like this magnetic response that can be picked up by the electrodes around the head. Well, if you take that tube phone and you pinch it off, that means that there's no acoustic signal making its way into the ear, but the earphone, the little black box with the earphone, the diaphragm in there that can give off all this electromagnetic response, that artifact would still be there. If you pinch it off and this squiggle at the beginning goes away, then that means that this squiggle is in fact acoustically elicited. So it's not artifact of the testing where the electrodes are just picking up something from the earphone. Yeah, this is called a cochlear microphonic. So presence of a cochlear microphonic with absent or grossly abnormal neurogenic waves, so waves 1, 2, 3, 4, 5, absent waves is suggestive. Well, it is indicative. That's the hallmark of auditory neuropathy spectrum disorder. And as I said, she had normal otoacoustic emissions. See how big and robust these emissions are, especially on the right. On the left, she had what looked like some absent emissions, but she had pretty good. Because of her auditory neuropathy spectrum disorder diagnosis, she was sent for genetic workup, and it turns out that she does have Charcot-Marie tooth syndrome, which is kind of a big deal. It's a progressive neurologic condition. That sucks. However, she's fluent in ASL. She's fitted her with hearing aids. She's actually really good with her hearing aids. Her receptive language is much better. Still has the trach. Will probably always have the trach. She may develop some verbal language. She's got a lot of medical supports, full-time 24-hour nursing care, but she's doing really well with school. She's making a lot of contribution. So she was a very interesting young lady. All right, switching gears, we're going to touch on this a little bit. In fact, I'm more than anything just going to ask you guys just read through these pieces, talking about what do we do? What do you do about these sensorineural hearing losses? Hearing aid fitting within 1 month. Fitting proceeds from our physiological measurement and a medical exam, so this has to happen very quickly. We want to maximize access to the acoustic features of speech, okay, within a range that is both safe and comfortable. You have to use prescriptive fitting algorithms. We have to consider the individual ear canal acoustics. We need verification and validation. Consider cochlear implant and FM based on the goals of the family. Do they want the child to learn to talk and to hear? If they have a severe sensorineural hearing loss, cochlear implant will help them to hear better than hearing aids will. But just because you don't have hearing doesn't mean you can't be successful. It works well. CI should be given consideration regardless. Just because a child has Down syndrome and severe to profound deafness doesn't mean that they shouldn't be considered a candidate for cochlear implant, for instance. Cochlear implant can be considered. Hearing aids are indicated for children with auditory neuropathy spectrum disorder. Infants and young children with unilateral hearing loss. Consider hearing aid fitting. In fact, it's coming along. Cross hearing aid, not recommended. Not at this time. You may consider doing a BAHA if it's just unilateral deafness. Otitis media. If a kid has a sensorineural hearing loss and they get ear infections, pretty much the recommendation is put tubes in their ears as quickly as possible. You don't wait to see if the otitis resolves on its own. You would treat middle ear dysfunction much more aggressively in a child with a sensorineural loss, because any additional conductive component on the hearing loss is very significant. So we had a protocol for managing children with sensorineural hearing loss. Between fitting with hearing aids as soon as possible, we verify the audibility using desired sensation level fitting algorithm. Reassess hearing every 3 months for the first year, and then if everything was stable, we would do every 6 months thereafter. Certain pediatric validation inventories. So just because the hearing aids are working and the child can hear with them doesn't mean they're doing something with the sound. There's some inventories called the Early Listening Function Test, or the ELF. It's you can look it up online, ELF. It's actually Phonak, I think, sponsored it, and an audiologist named Karen Anderson came up with it. Actually, I talk about it in my book. If you guys get a copy of it, you can see some of the details around it. And you have to be flexible and understand that the child is leading this, and you modify what interventions you use based on your expected success versus where the child is in terms of their success. They might surprise you. So here's some demonstration of hearing aids that were not fitted appropriately. They were way too soft. So this is on a VeriFit. Left ear hearing sensitivity on an SPL scale. You can see the blue line, so left ear and right ear. And what this is showing is green hash, this is for soft sound input, blue hash is for average sound input, and then purple is your maximum power output from the hearing aids with the 90 decibel input. And what you see is if the level that is measured through the hearing aids is above the threshold of audibility, which is the left ear and right ear, if it's above that threshold of audibility but below this targeted MPO curve, or what you would expect to be your loudness discomfort level, all of this should be up above the threshold of audibility and should be within their residual auditory area, which should be above the audiogram, basically, and below these max levels. These are tremendously underfitted hearing aids. These hearing aids are basically acting like earplugs. They're not doing a whole lot. Here's an example where things are actually really quite well fitted. So these little pluses, this is where, let's see, what is the prescriptive formula on this one? I believe it's DSL, DSL 5 child. How much audibility should you provide to a child with this degree of sensorineural hearing loss? MPO is below what the predicted loudness discomfort levels. Soft sound, the average level of that soft sound is right at their threshold of audibility. Average speech is the softest part of it is above threshold of audibility. The loudest part of it is below their LDLs. And even loud speech, it's a little bit louder, but it's still below the threshold of discomfort. So that's a well-fitted hearing aid. Considering that verification is does it work, validation is does it matter. Singer et al. Really, really awesome paper that talks about validation. Let's see. You have to do language evaluations, cognitive, social, emotional developments. All of that stuff works synergistically. Evaluations should be performed at regular intervals, should include assessment of oral, manual, visual mechanisms, as well as cognition. Spoken or sign language should be commensurate with the child's age and cognitive abilities. If they have any cognitive disability, then yes, spoken or sign language is going to lag behind, regardless of their hearing sensitivity. Really focusing on the acquisition of phonologic, pragmatic skills, syntactic, semantic, focus on the child's communication, and focus on the family's fostering of the communication abilities. So prior to universal newborn hearing screening, you may recall if a child had severe to profound sensorineural hearing loss, their reading by the time they would graduate from high school would be the 3rd to 4th grade. Their language levels would be that of a 9 to 10-year-old. Once we had universal newborn hearing screening, if they had mild to profound hearing loss, regardless of the degree, and they were in early intervention by the time they were 6 months old, they have language development that's ranging within normal by the time they were 5 years old. So over the course of those first 5 years of life, by the time they got to kindergarten, they're on track with their normal hearing peers. The purpose of early intervention is to prevent the significant negative effects of hearing loss on cognition, language, speech, auditory, social, emotional, and the academic difficulties that would have otherwise come from not knowing about the hearing loss until the child is older. You can pause and read this slide. Once you finish pausing, just read through it. This is just literally like the JCIH 2000 pointing out what demonstrates a quality early intervention program. Principles of early intervention. Again, pause, read. Yeah, pause, read. You can pause and read. This is a supplement regarding early intervention, a supplement to the JCIH 2007 position statement, published March 25th, 2013. That was it was an expansion on JCIH. Had 12 specific goals. I'll let you guys just touch base on this just quickly. Notes on validation. If a child was screened versus they were not screened for hearing loss, they were identified over 24 months earlier, 2 years earlier than if they were not screened. They were fitted with hearing aids about 2 years earlier, and they were enrolled in early intervention 20 months earlier. If they had a hearing screening and they passed but developed a hearing loss, they were identified slightly earlier than if the child had not been screened. Okay, so this was looking at Children, 64 kids with bilateral sensorineural hearing loss, 47 who were screened, 17 who were not screened. Follow-up study that did include some of these kids, 44 children, typically developing no cognitive impairment, cognitive disability. They had between mild to profound sensorineural hearing loss, all had hearing aids, some of those with profound bilateral, they had cochlear implant, from ages of 1 year to 72 months. The variables that they looked at, does it matter? The age at which the child is fitted with hearing aids, the degree of hearing loss in their better hearing ear if there was an ear difference, whether or not they had cochlear implant if they needed, if their hearing loss was of a degree that would designate, cochlear implant, how intense their oral education was. This is specifically looking at auditory development, so not sign language development. Parent-child interaction, and the number of languages spoken at home. These are the variables that the Sinninger et al. Paper looked at. So this paper, these 5 outcomes that were measured, they looked at speech perception, speech production, and spoken language. Again, it's very oral focused, so it was looking at how well does the auditory system help the child acquire spoken language. Again, not specific to say that that's better or worse than sign language, it's different. And so it was specifically looking at, for those children whose families opted to go a route where they wanted spoken language to be the child's primary mode of communication. They did regression analysis to determine what was important in this. The age of fitting hearing aids was the strongest predictor. It influenced all outcomes, the age of fitting of hearing aids. The degree of hearing loss had an influence on their speech production and on their spoken language. The degree of hearing loss did, but it didn't influence other outcome measures. If they had cochlear implant, if they needed it, that did also influence their speech production and influence their speech perception and language outcomes. So in summary, remember that 1-3-6, screen by 1 month, diagnose if there's hearing loss by 3 months, early intervention by 6 months. Timeliness of the interventions, very clear with the papers we just talked about. We talked about the minimal auditory test battery, talked briefly about verification and validation, as well as principles. Just bearing in mind that the age of fitting of hearing aids was the most important predictor of outcomes. The degree of hearing loss in cochlear implant use did matter as well. Okay, gang. Long stuff today. We'll talk again.